heart failure with preserved ejection fraction probably represents about half of all of patients with heart failure and is associated with a substantial morbidity and mortality. There is paucity of evidence-based proven therapies in patients with HFpEF. PARAGON was a randomized double-blind trial comparing sacubitril/valsartan versus valsartan in patients with heart failure and preserved ejection fraction. After a run-in period, patients were randomized to sacubitril/valsartan or valsartan, both twice a day. The primary endpoint of the study was a composite of first and recurrent heart failure hospitalizations and cardiovascular death. Eligibility included age over 50, ejection fraction of 45% or greater, NYHA class 2 to 4, and evidence of left atrial enlargement or LVH by echocardiography. They also had to have had an elevation of natriuretic peptides. Baseline demographics in this trial: mean age was approximately 73, 52% were women, and the baseline ejection fraction was 57%. Almost 80% were NYHA class 2, with clinical characteristics typical of patients with HFpEF, including diabetes, hypertension, and atrial fibrillation. Majority of patients were on an ACE inhibitor or ARB prior to randomization. Almost all patients were on a diuretic, and approximately 25% of patients were on a mineralocorticoid receptor antagonist. So the primary results of the PARAGON heart failure trial demonstrate an event rate of 14.6 per 100 patient years in the valsartan arm and 12.8 events per 100 patient years in the sacubitril/valsartan arm, yielding a rate ratio of 0.87, with a confidence intervals which just barely crossed 1 and a p-value of 0.059. Secondary endpoints demonstrated an improvement in NYHA functional class, improvement in the quality of life evaluation, and an improvement in renal function. In terms of safety, there was more hypotension but less increase in serum creatinine and potassium in the sacubitril/valsartan arm. Two subgroups are notable. Women achieved a significantly better treatment effect than men with a 27% overall reduction. Patients below the median ejection fraction of 57% also received a 22% reduction in events. In conclusion, there was a modest, non-significant 13% reduction in the primary outcome overall. Although subgroups should be interpreted with caution, it is notable that the inclusion criteria were identical to that of PARADIGM-HF, except for the ejection fraction. Therefore, sacubitril/valsartan may be beneficial in patients with HFpEF, especially those with ejection fractions in the moderate range and in women. This raises the issue of heterogeneity and phenotypes of patients with HFpEF.